Assalamu alaikum. Discussing the series of various pedicles now. We have mobilized the left colon, identified the gonadal vein, the ureter, and dissected the lower pole. We are marching towards the pedicle, following the gonadal vein, dissecting the area where the gonadal vein is leading us. We find the renal vein, and the patient is thin lean. The kidney was grossly hydronephrotic, secondary to neglected PUJO obstruction. We decompressed the kidney, and we found a lot of space for ourselves. Now we are dissecting the gonadal vein. As I already mentioned previously that the anatomy of the vascular system is such that the artery is usually found in the posterior inferior aspect of the renal vein. In order to reach to the renal artery, it is at times needed to dissect and clip and then divide the gonadal vein. This makes the approach to the renal artery very easy. It is usually safe in case of non-functioning kidney to dissect lateral to the gonadal vein and not come to the medial side of the gonadal vein, because this gonadal vein, if you are dissecting medial to the gonadal vein, then there are chances that we will encounter the lateral wall of the aorta. However, with passage of time and experience, one can appreciate various tissues, the vascular tissues, venous tissues, arterial tissues. You can differentiate between the fat and the lymphatic tissues. However, if you already have it in your mind that if you are dissecting medial to the gonadal vein, you may encounter the surface of the aorta, and then the chances of injuries are very slim. So we found the artery in the usual location. You can see that artery is quite long, and we have dissected the tissue around the artery, which is helping us to have a lengthier portion of the artery. The lengthier the artery, the more convenient it is to apply the clips. So you dissect the lymphatic tissue and the fats around the artery, and then you will find a lot of space. So you're also dissecting between the renal vein and the artery. It's kind of a dissection is made in the donor nephrectomies usually. So we have a lot of length of the renal artery. It is totally exposed. We can very easily apply 3 clips. This is the fuse of the artery, which means that we are very near to the surface of the aorta. This is the fuse here. Yes, this one. You can apply the clip here. Now we dissect. Instead of applying a single clip on the artery, we dissect the renal vein as well, so that all of the clipping is done in one setting. However, in routine, I usually prefer to dissect the artery enough to place a clip, and then I dissect the vein. So we place 2 clips towards the big vessel, 2 clips on the vein towards the big vessel or the midline, and 1 clip towards the kidney. And then we divide in between. Division is with the scissor and in chunks, not in one go as usual. And same is the case with the vein. Thank you very much for watching.